Hello, and welcome back to Yodo. I'm Dr. Sarah Bohn, and this is a continuation of the series on Sentinel Events. If you missed the introduction to this, look back at my profile for that one. The arena of information around this is huge, and I'm only covering a few issues. Today, I will limit Sentinel event information to falls. Falls constitute an important part of safety concerns and occurrences. Fair warning, there is some statistical data in this one, but there's no quiz at the end. A fall exposes a patient to unacceptable risk of harm. As with any adverse event, there are a few uncontrollable factors. The patient themselves can put themselves in harm's way and affect their own safety with regard to falls. About 2% of hospitalized patients fall at least once during their stay. This may not sound like a high percentage, but that is between 700,000 and 1 million people in the United States yearly, per the Agency of Healthcare Research and Quality. There are many reasons for in-hospital falls. To list a few examples, the patient is very ill when they're in the hospital, and it's an unfamiliar environment, and it can be unfriendly. Patients don't feel well, and they're away from their home. There is loss of their regular routine, and they lack privacy with staff constantly checking in on them. But it may not be available for that help to come when the patient wants the help. Loved ones may not be in the room to help reorient the patient, and although an episode of disorientation or confusion might be brief, it can be long enough for a person to try to get up on their own and take a fall. Ill patients are weak, they may have pain, and typically they're on unfamiliar medications. Other factors include they may not know how to run the TV, they may not be recalling which side of the bed that the bathroom is on, and when they wake in the middle of the night, they might forget to call for help. Additionally, response may not be immediate. Staff members may be with other patients. Room lighting might not be adequate. The patient might be tethered with wires on them for their heart monitoring or breathing monitors. An IV or oxygen cannula might be in place. Falls can occur when a patient is reaching for something, such as a phone, food, or a beverage. As you can see, this list is an extensive one. There is a video on the channel that discusses hospital safety. Please check it out for more information about how a hospital may not be a safe place. The numbers for falls in nursing homes are also worrisome. Studies of nursing home patients reveal that nearly 50% of the 1.6 million United nursing home residents experience a fall each year. 30% of patients with a fall will have an injury, and 10% of those, the injury is serious. The good news, bad news of this includes over time, there have been a continual decrease in the number of falls because of safety measures put in place. However, this is offset by the increasing age of patients that require a hospital or nursing home stay, and the increasing acuity of the patients has increased as well. The advancement of therapies, medications, and procedures enabling people to live healthier and a longer lifespan has resulted in that patients in hospitals and nursing homes are overall older, sicker, weaker, more frail, and take more medications than at any time in history. Thus, ensuring a safe environment for care while respecting patient choice and freedom to be mobile needs more attention than ever before. A fall in a facility, be it a nursing home or hospital, can easily result in trauma that can impair mobility and shorten a patient's lifespan, with the result of bringing death even closer. The patient population in palliative and hospice is by definition at the highest risk for end of life due to their medical diagnoses. Thus, the risk of a medical adverse event is associated with an even greater likelihood of patient injury. The disease process has progressed to the point that it now limits activity, independence, and has become life-threatening. These patients and their loved ones must determine what is most important to them as the time has become short. Some choose quality of life over quantity of life. A patient electing to ambulate when they are aware that it's not safe is risking putting themselves in harm's way. A fall with injury is a terrible outcome. A broken bone is devastating. A fall in a facility that is staffed around the clock that results in a fracture is a sentinel event. A broken wrist, for instance, may be called a fouche injury, fall on an outstretched hand, and this causes pain and requires casting, possibly surgery, and the ensuing decrease of strength may be difficult to recover for patients that are in this population. If the break is to a dominant hand, the patient might not be able to dress themselves, use utensils at mealtime, or get in and out of bed or chair easily. They will have difficulty in participating in activities, using their cell phone or the TV controller, and it can lead them to feeling isolated and depressed or helpless, as now they need assistance from others for even simple tasks. And I can promise you that patients living in a nursing home want to be independent. This group of individuals are rugged individuals, and they are quite determined to do things for themselves. Additionally, when a fall occurs, there may be more than one injury. A patient with a broken wrist might also injure their shoulder or neck or back from that same fall. Sustaining an injury that causes pain and decreased mobility is highly likely for a patient that is old enough to have osteoarthritis. When cancer has damaged bone integrity, the bones in that spot are weaker and more susceptible to fracture. When a bone breaks at the site of a malignancy, it can mean that the bone is not repairable by natural healing, and sometimes surgical intervention is not practical either. Inability to provide stabilization of a fracture is awful news. A fall with trauma with resulting hip fracture is unfortunately more common than we would like in our palliative hospice population. Patients with cognitive impairment from dementia are at particularly high risk. Many expert sources advocate that these be considered a Sentinel palliative event in addition to a Sentinel event due to the association with reduction in quality of life and a significant, statistically decreased amount of their 1-year survival percentage. Management decisions are complicated for this population, with many competing demands for the surrogate's attention. There are many medical evaluations that must be completed and in an expedited manner. The healthcare surrogate must decide regarding interventions quickly. There are many considerations, as there are multiple surgical and non-surgical options and a variety of implications for each of these choices. The patient's loved ones often feel pressured and fear making an incorrect decision, as some of these choices are made in the context of an uncertain prognosis. Now for some unimaginable numbers. Falls cause 95% of hip fractures in this frail population. The chances of a fall resulting in a hip fracture increases as people age in general. And for patients with dementia, the incidence of hip fracture is at the highest level compared to other frail patients or hospitalized patients. Hip fractures in the elderly are associated with an increase in all-cause morbidity and mortality. They have an overall mortality of 13% at 3 months and just over 25% at 12 months. For nursing home residents with advanced dementia, the mortality risk of hip fracture is even more striking. The data suggests in some studies at a staggering 35%, and in other studies an appalling 55% of these patients will die within 6 months of that fall and fracture, and 62% will die within 2 years. The average survival for those treated surgically is approximately 15 to 16 months. And less than 6 months on average for those treated non-surgically. Some studies indicate that 50% of these patients that are at the most frail will die in 3 to 4 months, as they're too weak, too frail, too sick from their chronic disease state to be a surgical candidate. The risks of surgery are greater than the benefit from the intervention. For those who undergo surgical repair, there is often a significant decline in their function as well. Unfortunately, even with physical therapy, aid assistance for activities of daily living, efforts by employees of restorative department, and interventions by nursing staff, a majority of these patients do not return to their prior baseline of activity and mobility. Related but not anticipated by patients and families is the amount of cognitive decline that also occurs after a fall and hip fracture. Predictors of significant loss of function and increased mortality after a hip fracture include older age, living in a facility, having comorbidities, advanced cognitive impairment, having a baseline dependence on others for activities of daily living, recurrent and or long hospital stays for any reason, and the development of post-surgical complications. Yikes, that is an extensive list and some staggering statistics. There are significant quality of life changes as well as an increase in mortality from the Sentinel event of a fall. When injury occurs in a person with advanced dementia, it is helpful if the decision-making surrogate has already clarified overall goals. An unexpected trauma certainly alters the trajectory of the patient and necessitates a review of the patient's anticipated prognosis and quality of life choices. For patients with a life-limiting illness, having clearly established goals through prior complex decision-making is key to ensuring that the patient's wishes are being respected. Having considered facts regarding the patient's goals already being completed is very helpful. Decisions made during a crisis may be clouded by emotions, and these might be panic, anger, sadness, or even guilt. This is where the palliative team can assist with guiding difficult conversations and support that decision maker. Let's look at a few specific situations. Consider an ambulatory patient with a higher functional level. Surgical repair with life-prolonging goals of care will likely be elected. The patient or decision maker will be made aware that risks of the surgical intervention do exist and can expose that patient to risks such as further pain, infection, pneumonia, surgical wounds, delirium, possible development of skin pressure injuries from being in bed, weight loss, constipation, blood clots, heart events, stroke, among other possible complications that are patient-specific. Now let's consider a non-ambulatory patient that has been bedfast and is dependent on others for their activities of daily living. Studies indicate that this population has a longer anticipated survival rate by electing comfort-focused goals of care after a hip fracture rather than surgical intervention. Patients with advanced dementia to this stage are unable to interpret their surroundings or make their needs known, and they're going to have their decision made by their surrogate. The life expectancy of this population is limited, but if surgical intervention is provided, surprising, the life expectancy is not lengthened, and the quality of life indicators reveal that this is reduced significantly. This is difficult information for our society to comprehend. The evaluation for treatment of patients with a fracture requires many medical personnel to coordinate with each other to determine the possible interventions with risks and benefits. A surgeon and an anesthesiologist, internist or geriatrician, palliative medicine physician, but others are also likely needed, such as possibly a mental health or geriatric psychiatrist, cardiologist, pulmonologist, or neurologist. The physician's responsibilities include evaluation of the patient across the spectrum of offered interventions with risks, prognosis, and then providing that summary of information to the decision maker. This discussion includes information on likelihood for functional recovery, patient values and preferences, review of advanced care planning instructions from the patient, possibly code status, and rehospitalization preferences. The benefits and burdens of surgical and non-surgical management must be clearly communicated. Enlightening the surrogate with the best and worst case as well as the most likely scenarios is commonly used. After the information is assimilated and provided to the decision maker, the pressure by the surgical team to decide quickly is a terrible demand. Studies indicate that nursing home population with advanced dementia suffering acute hip fracture that receive surgery within 24 hours have a lower mortality rate than others. For additional information and statistics, there is a reduction in the one-year mortality by 18% in patients that are operated on within the first 24 hours of the fracture, but that does not reflect the patient quality of life or mobility. 50% of the patient population that was ambulatory before fracture and surgery are likely to be able to ambulate eventually again after the surgery. Half of these patients will return to their prior mobility skill level. The other half will have a reduction in their mobility. Of the half that do not return to ambulation, almost half of these patients will die within the next 12 months. Because of these staggering statistics, patients with a life expectancy of less than a few weeks have recommendation for non-operative, comfort-focused end-of-life care with pain management. This is due to the real potential threats associated with the pre, peri, and post-operative events that I mentioned a little bit earlier. I'm not going to enumerate those in more detail here. The hardships from each potential outcome is why these are decided on a case-by-case basis. Another consideration of fall-related injury is when a head injury occurs. A severe consequence of a fall and head injury includes a subdural hematoma. This is a type of an intracranial bleed, when blood collects between the surface of the brain and the lining surrounding the brain, sort of like a blood-filled bruise under the surface of the skull. The skull is bone that nearly completely surrounds the brain and is unforgiving of the building force inside. Thus, blood expanding inside of this enclosed space can put an unacceptable amount of pressure on the brain that can cause permanent damage. This sounds awful because it is. The outcomes can vary considerably from no evidence of injury and the hematoma is picked up incidentally on imaging. Yet for others that do have clinical findings, it may include severe brain injury with permanent neurologic change, progressive worsening of cognitive function that has already been impaired and now having more rapid loss of memory, possible movement issues, seizures develop, headaches may occur, dizziness is possible, visual problems may be noted, unsteadiness is likely, mood changes, and even death can occur. What happens depends on many different factors, the location and the severity of the bleed. The outcome may appear disproportionate to the fall, and of course the patient's other disease states need to be taken into consideration. Patients with history of strokes, heart attack, or a clotting disorder that are taking a blood thinner at the time of the fall are at an even higher risk. Some of the newer blood thinners that do not require monitoring are not easily reversed, and intracranial bleeding may be very difficult or even possible to stop. Pre, peri, and post-operative intervention risks and benefits again must be considered, and they are quite high. An intracranial injury after a fall, again, is a sentinel event. When a patient in a medical setting falls and sustains an injury, the occurrence is terrible. It often prompts difficult decisions, and sometimes the outcome can be heartbreaking. We may want to put people in a plastic bubble to try to protect them, but that just isn't reasonable. Patients that have trauma from a fall, pain management is always a central component in the clinical management, while quickly assessing the patient's status and if they are a candidate for invasive repair. A wrist fracture may seem innocuous, but when the patient is a palliative or hospice patient, it can result in more rapid decline. When a fracture involves a hip, there are multiple orthopedic approaches based on fracture type and location in that hip. Whether total or partial hip arthroplasty is advised, fixation with a nail or screw is possible, but there are several options to consider. If the fall result is an intracranial bleed, the outcomes are quite worrisome. The goals of surgery may be for restoration of ambulation, but sometimes what can be accomplished is comfort. A few patients are not likely to do well with surgery, and comfort-focused care is more reasonable than a surgical procedure. It is important for everyone involved to communicate and have the same understanding of goals and outcomes. Facilities provide disclosure of information, and if the patient does not have the ability to understand the situation, the decision maker has to rapidly assimilate that information and let the medical and surgical team know what the patient would want if they had the ability to understand now what was happening. Remember, the surrogate does not choose what they want for the patient, but they're to state what the patient would choose. Fall safety is the responsibility of everyone. Staff at the facility, the patient, and their loved ones. Reasonable safety measures must be in place to prevent falls. Patients are not restrained physically or chemically. Safety processes are reviewed and modified routinely, and after a fall occurs, an in-depth incident-specific scrutinization is performed. Modifiable changes that improve patient safety are a constant in healthcare. Wherever a patient is being cared for in a facility that is staffed 24 hours a day, these processes are in place. Safe mobility is a priority, and we do the best that we can to balance safety with patient rights. Thank you for being here today. This is one more segment that is in this 3 planned segment on the topic of Sentinel events. So for patients with serious illness, we take these Sentinel events extremely seriously. See you again in the next one. Bye now.